So we know that in this particular case, the patient then relapses, 2 years later. And now we're, dealing with a patient who, has a rising IgM level. His lymph nodes are no longer bulky. And so the case has actually changed now when the patient comes back to us. We no longer are dealing with an oncological emergency. Now we have, other options that we can consider in the care of this patient. And what we would not want to do is perhaps add in alkylators again, because we don't want to potentiate any damage, to his stem cells. So this is really where we have some time to think about what's best for this patient and to manage him with perhaps other options for therapy. So in the second line setting where this patient does not need emergent therapy, we still would be mindful of using a proteasome inhibitor potentially. I think the fact that he still has adenopathy might sway me against that because ordinarily proteasome inhibitors are really good at cleaning out disease in the marrow, but not so good with dealing with extramedullary disease. I would avoid alkylators in this particular case. I would also avoid a nucleoside analog because, again, he's young. We don't want to put him at risk for secondary malignancies or myelodysplasia. And this is a particular, patient that I would actually get very excited about using ibrutinib at this point in time. We know he has the MYD88 mutation. We know he also has the CXCR4 mutation, but we're no longer dealing with imminent disease control that would be required. And the thing that one has to understand is that when one has the CXCR4 mutation, you have to set expectation. This is not somebody who's going to respond overnight to a drug like ibrutinib, but it may take a while. And that's why it's important for clinicians to know about the mutation status of an individual, because then you can set expectation. And you won't panic after a couple of months of not seeing a major response, understanding that it may take time in somebody who has a CXCR4 mutation. The fact that the patient also did well for 2 years, would also lend me to using ibrutinib along with rituximab in this particular case. One could certainly use ibrutinib alone, but since the patient did have benefit with the two drugs together, the bendamustine rituximab up front, I think it would be a very reasonable to use both drugs together. We know from the INNOVATE study, the patients who got ibrutinib and rituximab together showed, improvement over rituximab alone. And I think the combination for somebody who has a CXCR4 mutation would be reasonable.